Hello everyone, this is Miss Gerald. I wanted to go ahead and record this PowerPoint because I know you guys have a lot going on at this point with your pharmacology test and your first test, nursing test. So I wanted to record the safety PowerPoint so you can have this to refer back to at a later time, okay? We will still go through over key pointers in class and some other class activities, but I just wanted to make sure you had the voice PowerPoint this time. Please, it may be rather lengthy, probably about 45 minutes, but do not sit at one time and take notes with this PowerPoint. I want you to make sure you do it in parts, do it in sections, maybe sit about 20 minutes, take notes, write handwritten notes on your PowerPoint or paper according to each slide that I discuss here, okay? And then do another 20 minutes and then another 20 minutes. It will always be available on my YouTube channel for you to go back and listen over and over again. This information will be on test 2. Okay, so we're talking about safety and it will be on test 2. All right. NCLEX says that nurses need to be aware of safety and infection control practices and how the nurse contributes to help protect clients. And also in protecting clients, we're also protecting everyone on the healthcare team as well as their environment from hazards with safety and infection control. You have to be able to identify the right client that you are taking care of. You have to be able to reinforce education to clients about safety precaution. You need to understand how to use assistive devices safely, like such as a gate belt and a sliding board and the Hoyer lifts, those mechanical Hoyer lifts. You have to be able to know what to do in case of a fire. I know a lot of you work already in healthcare settings and you have to take the fire safety training every year that talks about just the practical, how to use a fire extinguisher, how to evacuate your clients using the pneumatic. So we have to make sure that we understand that using race and pass pneumatic, and we'll talk about that in this slide presentation. You also have to understand how to keep yourself safe. So you have to be able to use proper body mechanics as a nurse, because if you're hurt, then you can't be there to take care of your patient. Okay, so you have to understand how to move patients safely so patients don't get hurt, and as well as yourself do not get hurt. So you have to use proper body mechanics. We have to understand, and I know Ms. Hedgepeth has already talked about incident reporting, the importance of incident reportings, the importance of doing your hourly safety roundings, your safety checks on your patients, restraints, why we don't use restraints, or we use restraints as a last resort. And if we do have to put patients in restraints, how can we safely monitor those patients while they're in restraints? We have to understand safety across the lifespan. How do we teach parents about the importance of keeping their infants and children safe in car seats, and how they keep school-age children safe, as well as teenagers and the older adult. So you have to have a great understanding of safety when it comes to patient care and across the lifespan, as well as keeping yourself safe. So I encourage you, you have to pull out your NCLEX test plan and go over that section with safety and infection control, and make sure you're able to understand and recognize those concepts, okay? So everyone is responsible for safety. Everyone in the healthcare team is responsible for safety, have a knowledge of safety, have a culture of safety, from the nurses to the nursing assistants to the doctors, environmental services, everyone that is working in that hospital setting needs to understand and have a safety culture, okay? So the National Patient Safety Goals were designed to make sure that hospitals have standards in place. They are implementing different standards across the board to improve patient safety, to prevent sentinel events from happening. The focus of the National Patient Safety Goals are to focus on problems in the healthcare revolving safety and how to solve them, or really how to prevent them. So we're going to go in detail about the National Patient Safety Goals in class, because you have to have an understanding of the National Patient Safety Goals and why they are there, and what we do as nurses to implement these National Safety Goals. What do we do? What interventions do we do to make sure we are abiding by the National Patient Safety Goals? So the Joint Commission is this is a accredited body that accredits hospitals. Um, they ensure that hospitals are meeting safety standards, and they have implemented the National Patient Safety Goals for hospitals. We have to make sure that we are doing things to meet the goals. How are we identifying our patients? How are we communicating effectively among everyone on the healthcare team, among caregivers? How are we safely using medications? How are we safely doing things and practices to reduce patients getting hospital-acquired infections, such as CODI or CLABSI? How are we identifying those patients that are at risk to prevent them from committing suicide? How are we in the healthcare profession avoiding amputating the wrong leg, doing the wrong surgery on the wrong patient? So we have goals that the Joint Commission has put out, and we have an obligation. It is a requirement. We are obligated to abide by these National Patient Safety Goals. So the National Patient Safety Goals, these are some of the goals. We have to understand how we identify patients. How do we make sure we have the right patient? And one of the interventions that healthcare organizations are doing is that we make sure we ask the patient for their full name and date of birth. Full name, first name, last name. Also, if they are a junior or senior, we have to ask their full name and their date of birth. And while they are telling us that information, we have to make sure that we're looking at their medical armband to make sure that information is correct. Another goal is that we have to make sure we are communicating with the team. We have to make sure that everyone on the healthcare team is on the same page. And what do I mean by that? If this patient has critical lab values, abnormal vital signs, we have to make sure that the doctor is aware, and we have to make sure that we have notified the doctor and we have documented that we notified the doctor and the doctor's response. So if you notify the doctor or you call the doctor, leave a message, the doctor has not recalled back, you have to follow your hospital's protocol, and that protocol will tell you how many minutes you need to wait to call the doctor back again before you move up the chain of command. We have to make sure we are communicating appropriately among caregivers. If the nursing assistant checks vital signs or any condition about that patient that has changed, that nursing assistant or UAP have to notify the nurse. We have to improve communication among caregivers, any significant change that's going on with that patient. Okay, because what was happening, there were hospital errors that was going on simply because caregivers were not communicating, were not talking to each other. And the Joint Commission says this cannot happen. This is not safe practice. So therefore, there are interventions in place that caregivers have to do to show that they are communicating among caregivers, okay? I know one of the things that we do in hospitals, and you will find this whenever you start your clinical, any abnormal values, lab values, vital signs, any change in condition, the nurse must notify the doctor, and it must be documented with the doctor's response, okay? We have to make sure we administer safe medications. How do we do this? We follow the six rights, of medications. We make sure we ask the patient what their allergies are, and we go not only ask the patient, but we verify the allergies in the medical record before we administer medications. Okay, we look at lab values, vital signs before we administer medications. And that is, we never miss those steps, okay, because we want to keep the patient safe. There are interventions in place to reduce hospital-acquired infections. No patient should come to the hospital and get an infection while they're in the hospital. No patient should come to the hospital and have a medication error that happens because we as healthcare providers have missed a step. No patient should come to the hospital and have error or medical errors done to them simply because healthcare providers, and we are nurses, are considered healthcare providers, are not doing the necessary steps to cause harm to patients. The care that was intended to help patients should not harm them. So we have to make sure we have interventions in place to reduce the chances of patients getting hospital-acquired infections, such as urinary tract infections or infections from a catheter, which are CAUTIs, bed sores, bloodstream infections from their IV site, surgical site infections. Okay, this should not happen. You need to understand the chain of infection. This was something that I know you were taught in your prerequisite courses, but you have to understand the chain of infection, and we'll talk more about that in class, because if you take out one of those links in that chain, if one of the links are broken, then infection will be reduced. The chance of that patient getting an infection will be reduced. For example, you have to have an infectious agent. There has to be some type of infection that's present. If it's MRSA, C. diff, the flu, the coronavirus, it has to be an infectious agent that's present. A reservoir, you have to have somewhere that infection will live. Okay, typically in our lungs, in our urinary tract, in our GI tract, you have to have a reservoir. You have to have a portal of exit. How is this infection, how does it exit the body? You have to have a mode of transmission. How is it transmission? Through handshaking, through human contact. How is it? We have to have a port of entry. How does it enter the human body? And then you have to have a susceptible host who is susceptible to receive this infection. So if one of those links, those circles are broken, then the chances of the infection is lessened. For example, if you don't have a infection to begin with and a virus to begin with, then there's no chance of anybody getting the disease. If the coronavirus didn't exist, that link was taken away, then the chances are no one is going to get the virus. It doesn't exist. Another example would be of a reservoir. If we have the reservoir, would be, for an example, the bladder. That's a reservoir that urine lies. The bladder is sterile. Okay, so if you introduce a catheter into a sterile bladder, that increases the risk for infection. So what do? You keep the reservoir sterile. You don't put the catheter in. Okay, that will take away that link, therefore reducing the chance of the patient getting a CAUTI, catheter-associated urinary tract infection. So that's what I mean. Anytime you take a link away, it reduces the chance of the infection to exist. Okay, understand the chain of infection. and how that chain works. Any link that's taken away reduces the chances of infection. Other national patient safety goals, we have to make sure that the patients are getting the right medications when they are discharged home and when they are transferred to another floor or transferred to another facility, meaning from the hospital to the nursing home. Are these medications being reconciled? We have to make sure that reconciling medications are always done, meaning that those same medications that the patient are supposed to be on, that they continue to be on those medications when they are discharged home, they're on the right medication, or if they transfer to another unit in the hospital or transferred from facility to facility. Of course, we have to make sure we have interventions in place to reduce falls. We have to make sure we have interventions in place to improve and recognize when a change of condition happens. Okay, and we do this by our hourly rounding. We do this when we come into every encounter with that patient. We are always assessing to see if any changes in that patient's condition, and then we communicate appropriately. Other national patient safety goals, reducing clinical alarm system. Are these clinical alarms working? Clinical alarms meaning the bed alarms. Do they work? The chair alarm. We have to reduce clinical alarm system failures is what we're saying. Are we checking the clinical alarms on the bed? Any equipment, the EKG equipment, the crash cart, the cardiac monitor. Are these clinical alarm systems working effectively? Because if they don't, then if the cardiac monitor doesn't work and doesn't alarm us that the patient is not having the right rhythm and the patient codes, the heart stops, that's not good. We have to make sure that the clinical alarm systems are working. If the chair alarm or the bed alarm is not working, the patient falls, that's not good. Okay, we have to have universal protocols in place for preventing the wrong site, wrong procedure, and wrong person getting the surgery. And we have to have interventions in place to reduce the risk of suicide. If a patient is on suicide precaution, what does that mean? What are we doing to make sure this patient does not kill themselves while they're in a healthcare setting? You hear that all the time. It's so sad that patients are killing themselves under our watch, jumping out of hospital windows, hanging themselves in a hospital bed. Okay, that's not good. The Joint Commission says there must be standards in place to keep patients safe from harm. I found this cartoon on the website. I just thought it was cute. Just wanted to share it with you. A patient saying, "You got the mark on my hip to avoid making a mistake." And the surgeon is saying, "Yes, we have to do this. There have been incidents in the past where surgeries have been performed on the wrong side." How do you think that make a patient feel? They're getting ready to go into surgery, and the surgeon has to mark on their leg to make sure they have the right leg and they're doing the right procedure. Will it make a patient nervous, or will it make a patient feel safe? Think about that. Safety. It's the nurses. One of the major responsibility of nursing is to keep patients safe. So when you're answering your NCLEX questions and you're thinking about the prioritizing, Maslow hierarchy of needs, ABCs, after ABCs, which that is a part of safety, it's all about safety. It's the major nursing responsibility. Maslow hierarchy of need is about safety. It starts at the bottom. Okay, safety. We know at the bottom that means that's the most major responsibility. That's the priority. It starts at the bottom on that pyramid and then it works its way up. But at the bottom is where it starts, means that's the highest priority. And as it goes up that pyramid, that's the least priority. Deaths from hospital errors are ranked the third leading cause. So patients come into the hospital and they die from hospital errors that we as healthcare providers make. It's the third leading cause of death, hospital errors, according to a recent study by Johns Hopkins Hospital. Guys, that is not good. The third leading cause of death is from hospital errors, infections, falls, wrong surgeries, things that could have been prevented. So what are some contributing factors to an unsafe patient environment? We know they already have risk factors in place. We know this. That's why we as healthcare providers have to always be proactive and have interventions in place to prevent these errors from happening. We know there are risk factors. We know there are factors in place. So then what are we going to do to mitigate or to lessen these factors, okay? Or to acknowledge these factors, but then we have interventions in place because of these factors, is what I'm trying to say. So we know age is a factor. If a patient, due to the patient's age, that's going to be a factor to prevent, to contribute to an unsafe environment, from a toddler to an infant to an elderly person. Age is a factor, so we have to censor our care, safe care practice around their age. Ability to understand. Do we assess this patient's ability to understand what we're teaching them? If we're telling them to call us, if we're telling the elderly patient to call us, use the call bell to call us when they need help, do they understand? Are they cognitively aware of what we're saying? Okay? If we give them information to read about their safety of their medications, are they able to read? Are we talking to a parent who's a teenager or adolescent about their child who's a 2-year-old? So we have two risk factors here, the age of the child and the age of the parent. So we have to take this into consideration when we're providing their care plan. Impaired mobility. We know patients have their mobility that are impaired due to surgeries, due to just their aging process, and they have to use assistive devices. Communication is a risk factor. Or the patient, if they don't speak English, if they can't hear, see, there's sensory deprivations that are in place. Pain, if a patient is in pain, any delayed assistance, that contributes to an unsafe patient environment. Equipment. We know equipment in that room increases the patient's unsafe environment. If there's multiple equipment in that room and there's clutter in that room, if there are multiple lines, IV lines, oxygen tubing, bedside commodes that are in the room, all of those are equipment that can contribute to an unsafe environment for that patient. And we have to have interventions in place to mitigate or to take care of this and keep that our goal is to keep that patient safe. So age-related factors, pay attention to these next two slides. We're talking about age-related safety factors. In infants, their main reasons why they have unsafe practices is because they're unrestrained. They're not in safety in car seats. They fall off of changing tables or off the bed because they are being left unattended. Abduction. We have protocols in place to prevent infants from being abducted from the hospital. Okay? Know that. Please know these age-related safety factors. Toddlers, the main one for toddlers is accidental poisoning. That is the main one. Yes, burns, being electrocuted, drowning, falling downstairs, but the main one for toddlers is accidental poisoning, because toddlers like to explore. They like to get into things. They will get into anything and they want to explore. They're putting things in their mouth. So the main one for toddlers is accidental poisoning. Okay, are you hearing me? Accidental poisoning for toddlers, infants, or falls or unrestrained in the car. They're not in a car seat. Infant abduction. School-age children is play-related injuries. They're having accidents from injuries. And it's usually from horseplay. Play-related injuries or just on the playground. Okay? School-age children, play-related injuries. I know my son, I think he was in the fourth grade. He was just outside running, and they were doing relay races on the playground at recess, and I get a call while I was at work that your child has fallen. We think he's broken his arm. And I'm thinking, oh my goodness, this is typical though. School-age children, sure enough, I got off work, we got him to the ER. He had broken his arm. Okay, so it happens. But what do? We have to teach our children all the time. We're telling them constantly, be careful, be careful. But sometimes things just happen. School-age children, play-related injuries. Their main concern is having fun. They're not thinking about the injuries that could happen. Adolescents, sports-related injuries. And then adults is just simply ignoring safety issues. We know they have sensory changes, which means adults, their hearing decrease, their vision decreases, and then they start having multiple disease processes that can put them at risk for safety or unsafe practice. So let's talk about some environmental hazards. The ones I really want you to focus on is the latex sensitization, falls, and burns, and what we do with patients that are burns or their fires, okay? So environmental hazards, we know patients are having more and more latex allergies. We find this, and guess what? Latex is just about everywhere in the healthcare setting. It scares me when a patient come into the hospital and they have a latex allergies, because I know there's so many of our medical equipment, such as Foley catheters, gloves. My goodness, number one, gloves. They're made of latex. So I have to make sure that the latex gloves are not in that patient's room. If they have to have a Foley catheter, I have a different type of catheter for that patient. If I do come in contact with latex from another patient, well, that's why I have to make sure I use hand hygiene. I'm washing my hands, and we're supposed to wash our hands before and after every contact with each patient anyway. But this is another reason why we don't want patient to come into the hospital with a latex allergy, and we don't do everything we can to protect that patient, and they die from an anaphylactic shock because of latex that we have used in their care. That's sad. Does it happen? Unfortunately, yes, it does happen. That's why healthcare providers, the Joint Commission says hospitals will have measures in place, such as the National Patient Safety Goals, to keep these patients safe from harm. And that just talks about different types of latex reactions. You really don't have to know that for testing purposes. That's just FYI. So again, how do we prepare this patient from having a latex-free room? We stock the room with latex-free equipment, and I said that any type of resuscitation equipment, gloves, any client care equipment from dressings, IVs, anything. We don't want to have any latex, and we need to make sure we alert Central Supply, so we always make sure this patient has a latex-free room. We do not need to stock that room with latex items, okay? We need to make sure that room is cleaned thoroughly so there's no residue from powdered gloves or have latex glove. And we need to, importantly, here's another one, going back to the communication among caregivers, one of the National Patient Safety Goals, we have to communicate with other departments the need to use latex-free equipment throughout the hospital. The patient is not always going to be on your unit. They go to procedures, they get x-rays, they get ultrasounds. Transporters come and get your patients and take them to these procedures. Everyone we need to communicate that's going to have put their hands on this patient or take care of this patient, we need to communicate among healthcare providers the importance of this patient's care. That's why communication among caregiver is a national patient safety goal. That's just, again, what things we should do to keep the environment safe from latex. So let's talk about burns. Another safety hazard in hospitals are burns and fires. typically from electrical fires. It can happen. Think about all of the equipment that is in a patient's room. In the ICU, they have multiple monitors and machines. You have the um, cardiac machine, you got the intubation machine, oxygen, IV pumps. I mean, it's so many electrical outlets that are being used that there's no wonder that electrical fires can be one of the number one causes of fires in the healthcare facilities. It's related to electrical causes. Okay, we have to have measures in place that in case a fire does occur, what are we going to do? Okay, and we know the first thing we do is we rescue the patient. We move the patient away from the area that has the fire. Then we'll sound the alarm. We attempt to contain the fire and or extinguish the fire if that's possible. But we use the RACE acronym. We just need to know our fire plan. We don't come to work and think, hey, there's going to be a fire today. What do? That's why a lot of hospitals have fire drills. Take it seriously, guys. We need to understand and know our fire plan. What will we do in case of a fire? How are we going to evacuate? We can't just leave our patients there. What is the plan? Know your hospitals or whatever place you go to work. Know the fire plan. And there's the acronym or the mnemonic for to make sure we have interventions in place to rescue patients from a fire. We first rescue, alarm. We put the alarm in place called 911. We contain the fire if possible or confine the fire if possible, and we extinguish. Okay? Roles and responsibilities. We need to make sure as a nurse we know what do we do as a nurse. And the main thing we're going to do is rescue that patient. Alarm. Okay, sound that alarm so we can get help there. Contain the fire. We close all the doors, the fire doors in the hospital. That's why when there's a code red, which typically means a fire, we contain it by closing the doors to the rooms. The hospital doors to the patient's rooms are fireproof. The doors to the unit are fireproof. We contain the area, okay, and we evacuate. Know your agency's plan. That's the main thing that you need to take away from here. And that we keep the patient safe and we know the acronym RACE. That's just, again, basically what I've been saying. It's just summarizing it. These are some pictures of how we can evacuate clients. We need to make sure we get the clients that are able to walk, ambulatory clients first. Some of those ambulatory clients, believe it or not, could help us with the other clients, getting them to a place of safety, okay? And that picture there under B is the two-person assist to help those patients who cannot walk. Picture C is the sled. We put the patient in what we call a sled, and that's exactly how it looked at Cape Fear Valley. One of their LTAC hospitals, Highsmith Rainey, is a long-term acute care hospital. Typically, those hospitals are, those patients in that hospital are non-ambulatory. So they have to, their employees, everyone, have to have the sled training. How do we slide these patients down the stairs, because you can't use the elevators in a fire. So how do we safely get these patients in the sleds and slide them down the stairway to say a place of safety in case of a fire? So we have to have that training. Okay? Evacuate the patients who are ambulatory. Get them out first. Maybe they can help evacuate some of the non-ambulatory patients. And we can also use the sled. There's the acronym for PASS. PASS, pull the pin, aim the nozzle, squeeze, and sweep. Back and forth motion at the base of the fire. Type of fire extinguishers. Type A is for paper, wood, fabric. Type B is for fires caused by gasoline or other combustible liquids such as oil or flammable gases. Type C are used for electrical fires, and that's typically what we have in our homes. and then the facilities are type C fire extinguishers. All right. Now, these next couple of slides are FYI. You may see this on your NCLEX, and it's just wanting you to know. Um, NCLEX wants to know that we are aware of other environmental hazards. We know that airway can be obstructed in our patient. Our patient can stop breathing. What are we going to do to keep our patient safe? We're all CPR certified. And that is basically what NCLEX wants you to know. If a patient stops breathing, what are you going to do? You're going to provide CPR, airway, breathing, circulation. That's typically what these slides are saying. If a patient has carbon monoxide poisoning in the home, what are you going to teach your patient? They need to have a carbon monoxide detector in the home. If they do have carbon monoxide poisoning, sometimes those signs and symptoms can be similar to the flu. They can have muscle weakness, really fatigue. Okay, except the difference is their skin will be a cherry red skin color for carbon monoxide poisoning. They need to seek help, call 911. Drowning, we know, especially with adolescents and children, drowning can happen and interfere, can impose a hazard, environmental hazard. Again, what do we do for accidental drowning? We perform immediate CPR, okay? We want to teach, main thing is prevent, and we teach how to prevent one from drowning. You never want to go swimming or be in a swimming pool by yourself. You need to know that the areas that you're swimming in, how deep is that water that you're swimming. Always make sure there's a lifeguard on duty or safety equipment to pull you out of the water. Okay, know your surroundings. If it does happen and you're at a pool or I guess like the Lifestyle Fitness Center that has a pool there, and you are certified in CPR, you are protected by the Good Samaritan Act to provide immediate CPR and get help. That's just FYI, really not going to be tested on that material part there, but we just need to know we need to make sure we keep our patients safe. And these are other environmental hazards that can happen. Fires, swimming, carbon monoxide poisoning, just typical household poisoning, fires, okay? Electrical shock, we're not going to go into that. We just talked about basically what do we do, the acronym PASS, RACE, for electrical fires in the hospital. Poisoning. We know that poisoning, one of the toddlers are most at risk for poisoning inhalation. It's because they like to roam, they like to explore, put things in their mouth. So poisoning happens more commonly in the homes than in the hospital. So we have to make sure we are teaching safety in the home, in the patient's home, especially when patients are getting ready to be discharged home. Okay, teaching in the hospital discharge teaching starts on admission. So we need to teach these patients, are your medications locked in a safe place in the home? Are there children in the home? Okay, make sure that these household chemicals and medications are in a safe place to prevent accidental poisoning. All right. Poison prevention. We just said educate parents, educate children. Medication containers. Make sure you have especially for our older adults who have cognitive impairments, or even just they have so much going on at home. For example, I tell you guys this, my mom, she's only in her 70s, but she has a lot going on with her medications and keeping up with my stepdad's medications, my grandmother's medications. So I tell my mom, you need to get a pre-filled medication container. Go to the Dollar Tree. And she says, well, I only have 3 medications to take. I said, it doesn't matter. Use a pre-filled medication container that can alert you and remind you that you have taken your medicine each day, so you don't double or overtake your medication because you've forgotten. Okay? So we have to educate to prevent poisoning prevention, or medication overdose, which is typically another level of poisoning prevention. Okay, let's talk about falls. Let's spend a couple of moments here on falls. We know falls is the most common accident that can happen in the hospital, and seriously, they have serious consequences in older adults. If older adults fall, they can break a hip. They can fall, break a hip, have surgery. One of the major complications from hip surgeries are PEs, pulmonary embolism, fat embolisms, and you'll learn about that. Then they can end up dying from embolism or from infection, all because they fell. So do you see how it's important for us to prevent falls? We have to have interventions in place to prevent falls. Okay, contributing factors. We just said that their visual are impaired. They have their gait is unsteady. They have to use a walker or a cane. Their balance is off. They take medications to help prevent lower blood pressure or lower their heart rate, or pain medication for arthritis. And all of these medications can help contribute to them or put them at risk for falls. So we have to have fall prevention interventions in place. Other contributing factors to falls, urinary urgency. If you have a patient in the hospital and they have to keep getting up to use the bathroom, urinary urgency, they're going to get up, keep getting up. They're connected to all kinds of tubing. They have their own medications, blood pressure medicines, heart medicines, pain medicine, and they're going to, more than likely, they're going to fall when they get up. Urinary urgency. Environmental factors, if the room is full of clutter. Social factors, if there's a lot of people in the room. They'll get confused sometimes when they're in the hospital. Older adults have that sundowner syndrome. When late in the evening, when the sun goes down, they get more confused. Typically when they're in a new environment or in the hospital, that brings on confusion. There are other, so we have to make sure we are aware of this, and we have to protect them and have interventions in place to prevent falls. All right, so what do we do? What do we do first? We assess. We know we assess. What do we assess? We determine their risk factor. Okay, we assess to make sure that we have fall prevention measures in place, the appropriate fall prevention measures in place, and we'll talk about that more in class. But you know the fall prevention measures: non-skid socks, um, bed in the lowest position, call light in reach, all of the personal belongings in place to that patient, meaning their cell phone, their remote control to the television, their telephone in the room. The bedside commode is not at the bedside, so it means the bedside commode will be in the bathroom where they can't see it. So if the patient can't see that bedside commode, they won't try to get up on their own to use it. They will call for help so they don't fall. Okay. The Morse fall scale, you have to know this. It's a scale that is utilized to assess the patient's fall risk level. Now, some facilities are used the Morse fall scale to say how, if the patient is in at a low fall risk, medium fall risk, or high fall risk, and according to that fall risk will be interventions accordingly to the fall risk. But I can tell you, at Cape Fear Valley Hospital, and I'm almost certain at Southeastern as well, every patient is on a fall risk. Because if a patient comes into the hospital and they are sick enough to be admitted, then they have something going on that will put them at risk for fall. They have an IV, they're on certain medications for pain, blood pressure, heart, nausea and vomiting medicine. They have something that caused them to be at risk to be admitted into the hospital, so that puts them at risk for fall. They're just in the hospital. Older adults just being in the hospital can cause them more confused. They're at risk for falls. Okay, so we do this Morse fall scale assessment. It does categorize them, but every patient in the hospital is on a fall risk at Cape Fear Valley. Now, you have to make sure that you assess your patient and go by the facility that you are working for. But just know that the Morse fall scale is an assessment used to determine the level of safety risk for the patient. Okay. And there are six risk factors that they look at. The history of falling, you give them a score of 25. Secondary diagnosis, meaning if they're here in the hospital for abdominal pain, but they have a history of hypertension, visual impairment, they've had recent hip surgery, those are secondary diagnoses, and they get a score of 15. Ambulatory aids that they have to use a 15 or 30. If they have an IV in place, if they have problems with their gait or walking or transferring, they get a 10 or a 20. And then a mental status. If they're alert or not alert, they get a score of 15. And that is all in your book, okay? So these are the outcome. If they score between 0 and 24, you put them on a level 1, fall precaution, 25 to 50, level 2. Greater than 51, that's the highest, and it's a level 3, and you have other interventions that you put in place, okay? Fall prevention strategies. I know you have heard myself as well as Ms. Hedgepeth talk about hourly rounding. Intentional hourly rounding. You will be doing hourly rounding at the hospital. Hourly rounding, it is best practice. It has been proven that if nurses will complete hourly rounding, meaning you are going and making rounds, checking on that patient every hour with interventions in place, you are assessing their pain. You are assessing their possessions, making sure their personal belongings are within reach. They are in a comfortable, safe position. They are escorted to use the bathroom or the potty. Okay, that means the 4 P's: pain, possession, position, and potty. Bathroom will be called potty. The 4 P's are in place. This will help to prevent falls. Okay. And we do this every hour. We are intentionally going into this patient room and intentionally asking them, let me help you go to the bathroom. Don't just say, do you have to go to the bathroom? Because the patient will say no. They're more than likely to say, no, I'm okay, because they feel like they don't want to bother you, or they know it takes them a little longer, and that's how some patients are. So they would typically say no. That's the reason why we don't say, do you have to go to the bathroom? That close-ended question. We say, let me help you to the bathroom while I'm in here because I have the time. And we assist them to use the bedside commode, the bedpan. Make sure they're in a comfortable position. That bed is in the lowest position. They have the pillows that they are comfortable. Do they need anything for pain? Okay. Are all of their personal belongings in reach? Their cell phone, call light, bedside table. Hourly rounding, fall prevention strategies. Also, we'll make sure if that patient is confused or score high on a Morris fall scale, we put that patient close to the nurse's station. Okay, when that patient goes to the bathroom, if they're able to walk to the bathroom, we stay with them. We don't leave them on the toilet and then tell them to pull the call light when they're finished. No, we stay there with them, okay? All right. Okay, let's talk about restraints. Restraints are a protective or adaptive device to promote safety, client safety, and a postural support which the client can release independently. That's a restraint alternative, excuse me. But a restraint is any type of chemical or physical restraint that will prevent that patient from moving or falling out of bed or pulling out medically necessary lines or tubes. Okay, it can be a physical restraint, which would be soft wrist restraints, a vest restraint, or it can be a chemical restraint, meaning a restraint that can alter them mentally to help keep them calm. That's a medication, a chemical restraint. Okay, purpose of restraint should be to keep the patient safe. It's not should be the convenience of the staff, but it's simply to keep that patient safe from falling out of bed, from pulling out necessary tubes or lines that they need, such as their IV, NG tube, Foley catheter, oxygen. Okay, but if you do use restraints in a hospital, they have to be closely monitored. We document on restraints. It depends on what type of restraint it is, anywhere from 15 minutes if it's a behavioral restraint, or if it's a physical restraint, every 2 hours. Some facilities may do every hour, but at our facility that I work at Cape Fear Valley, we do every 2 hours. But you have to know your facility. So I'm not going to test you on the every hour, every 2 hours. I just need you to know that restraints have to be closely monitored and regulated. Restraints cannot be used to discipline a patient. They're only used to keep the patient safe. Okay, they have to be used as the last resort after you have utilized every other resort. What are some other interventions, that can be used instead of a restraint? If you have a confused patient and they keep climbing out of the bed, getting out of the bed, what can you do? You can ask a family member to come and sit with that patient. You can have a sitter where we use a UAP or CNA to sit in that room with that patient. Okay? And if that doesn't work, we really use restraints as a last resort. Patients have died in restraints. That is a never event if a patient dies in a restraint while restrained. It has happened. Okay? If you use restraints, know that restraints can increase a patient from being confused. It can actually increase the confusion level when they're in restraints. Think about it. You're tied down. You can't move. You can't move your arm. Can you imagine how a patient feels? Think about yourself, how you would feel if you could not move your arms and legs. Okay? It can cause chronic constipation, incontinency of urine and bowel, infection because you can't move. You can't get up and walk around. It can put you at high risk from getting pneumonia, bed sores. That's why we have to monitor these patients every 2 hours. We have to do range of motion with these patients. We have to offer them hydration, nutrition. We have to make sure they can use the bathroom. Okay. We have to check their circulation, check their skin. All right. We have to monitor these patients very closely. All right, like I just said, there are certain protocols that are used accordingly to each facility, but just know restraints is the least, it's the last resort that we use. We use other interventions first, and we use restraints as a last resort. Okay, if a patient is in restraint, we have to monitor them closely to prevent what we were saying that can happen with the patient: skin breakdown, hydration. We have to monitor their hydration status, make sure they can go to the bathroom, circulation, okay, range of motion. All right, what are some nursing implications? We have to make sure we recognize safety hazards. We always assess and recognize those hazards. We identify patients at greatest risk for injury, such as toddlers, children, school-age children, adolescents, elderly patients. We identify several nursing diagnoses that's related to safety, and we have interventions in place that can prevent harm from patients. Okay, client safety is our number one goal. It's our responsibility, number one responsibility for nursing practice. The care that was intended to help patients should not harm patients. All right, general gerontologic considerations. What do we do for our elderly? We know it's the number one cause of safety issues or falls, and they can really severely injure themselves. They can break bones. Okay. If an elderly patient falls, it robs them of their independence. Now they're dependent upon a wheelchair, have to be turned, repositioned. They can't even walk anymore. So we want to make sure that they have well-fitted shoes, non-skid socks, non-skid soles on the bottom of their shoes. Most falls occur in clients who are age 65 and older at home. Not in the hospital, but at home. So we have to make sure we are teaching the patients how to be safe in their home. No scattered rugs in the home. Okay? Nowhere in the home. We have to make sure that they are using their assistive devices at all times, that they have adequate lighting in their home, that they know how to be able to dial 911, that maybe they have a medical alert necklace around their neck that they carry at all times, okay, while they're in the home. We want to prevent falls in the hospital as well as the home. We have to teach them home safety. Assess their home to make sure there are no scattered rugs, and make sure that there are no cluttered. We know older patients, they love to keep their homes cluttered with just, oh my gosh, my grandmother, her living room, I know we counted one time she had I think it was 6 tables in one living room. I said, Grandma, you got to get some of this cleared out. She has to walk with a cane now. She had a fall. Luckily, it did not sustain any injury, but we want to prevent that from happening again, and we have to make sure. We had to go in and declutter her home and educate her the importance of using that cane at all times while walking in her home. And those are just some other considerations. You can read those. I just talked about a lot of them. Lighting, decluttering, assistive devices. Responding to emergencies, the only thing you have to know is that we assess that patient, assess the general surrounding. When you go in that room, is that patient breathing? Is that patient alive and well? Meaning the breathing is regular breathing. It's not shallow breathing, agonal breathing. They're not bluish in color. They are safe. If not, do we need to notify rapid response or code blue? We respond to individual emergencies. Is the patient choking? We respond as healthcare providers to each patient's emergency. Mass casualty. With this slide, just know that every hospital has protocols in place for mass casualties. What do I mean by mass casualty? If there is a shooting in the area, multiple people have died and they're getting ready to influx and come into your hospital. If there's an airplane crash, a bus crash, a bombing, and there's any mass casualty, hurricanes, tornadoes that have a lot of people that are hurt, wounded. There are protocols in place for planning mass casualties. A lot of facilities will have drills, mass casualty drills, where everyone comes all hands on deck. Even nurses who do not necessarily work bedside care, like your nurse managers, your directors of nursing, but everyone comes into the hospital to help. If it's nothing but passing out ice to patients, making sure patients are safe, to talk to patients, to console patients, to give out blankets to patients, to check vital signs, to move equipment, to pass out gloves, every hand's on deck, okay? And you really, at this point, we just need to know that the goal of mass casualty events is to make sure that we have the highest number of people to survive first. So those patients that are likely to survive, those are the patients that we're going to see first and take the priority. And I know this is a ethical dilemma that students tend to have a hard time to wrap their brain around, because we want to save everybody in mass casualties events. We cannot. We have to treat those first that are most likely to survive. If those that are so far gone, and we have to just let them die. We have to save the ones that we know are going to be most likely to survive. And that's a whole nother protocol in disaster triage assessing, that we assess patients. We give them a green tag, a yellow tag, or a red tag when they come into the ER with a mass casualty event. If they have a green tag, those are the ones that we're seeing first. They're walkie-talkie, maybe some cuts, few bruises. We're going to treat those. Yellow tag, they have some maybe first-degree burns, but some maybe a broken leg, some cuts that we can get them into surgery, and they do have a more likely chance to survive. But those that are red tag or black tag, that means they are getting ready to die, and we let them die. Okay, or the black tag means they're dead on arrival. The red tag meaning we get to them last, because we got to save the green tag and the yellow tag first. Okay. Workplace safety. This is when you are keeping yourself as a healthcare provider safe. Body mechanics, using never lifting by yourself, always asking for help to help you to lift a patient or move a patient, using Hoyer lifts at any time that we can. We have a no lift policy in place at RCC, as well as a lot of healthcare facilities, because of patients falling and nurses hurting themselves. Okay, so we don't even want to hurt ourselves. We want to keep ourselves safe. As future nurses, keep yourself safe as well. No lift policy. Do not lift by yourself. Seek help to lift. Use Hoyer lifts or any other mechanical lifts in the facility to move and reposition a patient. Proper body mechanics. I'm not going to read those. You can read those for yourself. Again, proper body mechanic. Read through those. You'll be make sure you have a few test questions on those, because you have to keep yourself safe, okay, when moving and lifting objects. Unsafe practice. What influences us unsafe practice at work with healthcare providers? We don't get rest. We come into work working 12, 13, 14-hour shifts, sometimes 16-hour shifts with lack of rest. Unfortunately, some healthcare providers abuse alcohol, other drugs, prescription drugs. It puts them at risk for unsafe practices, for getting hurt in the workplace. That's why some facilities will randomly do drug testing, or you get a drug test before you're hired. Radiation, we need to make sure that we minimize exposure to radiation. We need to always make sure we are aware that we are away from radiation, distance for radiation, time for radiation. And what do I mean by distance and time? Meaning we are spending the least amount of time with that patient so we don't get exposed to radiation. We are furthest away from that patient. Distance, that's why if a patient is getting an x-ray, the x-ray tech would tell us as the nurse to step out of the room and step away, distance from that exposure of the radiation. And shield, if you have to work in an area of radiation, or you're working with patients with radiation, then you have to have a protective badge that shields you from the radiation. You have to wear a film badge, is what they call it. But you as students, we will not have you working with radioactive areas in clinical, or working with cancer patients who receive radiation and chemotherapy, because we want to make sure that we minimize your exposure, or you don't get exposed to radiation. But that is just FYI. That again, that's environmental safety in the workplace. Okay, minimizing exposure to radiation. And your MSDS sheets, material safety data sheets, if you do happen to come in contact with a chemical or a poisonous chemical in the workplace, every workplace has a MSDS book that shows you what that chemical is made of and what you need to do, what's required for you to do in case you do have an exposure to a chemical, even to a simple chemical as whiteout. That's a chemical. Alcohol, rubbing alcohol is a chemical. So make sure you are aware that, and you know what MSDS sheets are for. Is just a book that tells you the type of chemical and the potential harm and what to do if you are exposed to that chemical. That's all you have to know about the MSDS sheets. Okay. Now the next 8 slides are just NCLEX practice questions. We would do these during supplemental instruction. I'm not going to go over them now, be able to answer them, and we will go through them in supplemental instruction time. Okay? All right, thank you guys. I know that was about an hour time frame. Again, listen to each one of these slides, read these slides, have these slides to help guide you to where to read in your book. Take notes. Email me if you have any questions about safety practices and infection control. All right. Thank you.